My name is Dr. Ali Balharith, and I'll be discussing with you a little bit of an updates on hypertension since American Heart Association and other organization, they changed the definition of hypertension. We used to the number 140/90, but actually that was previously, this is stage 2. So the definition of hypertension actually is 130 systolic or above, and 80 of diastolic or above. As you can see here, the normal blood pressure less than 120 and the diastolic less than 80. Elevated blood pressure will be called at 120 to 129 systolic and less than 80 of diastolic. High blood pressure, as we mentioned, as defined, more than 130 systolic, so 130 to 139 or 80 to 89 would be stage 1 of hypertension. Stage 2 would be systolic of 140 or higher and diastolic of 90 or higher. Then you get to your hypertensive crisis if the systolic is higher than 180 and or higher than diastolic of 120. All clinical trials data had showed that antihypertensive medication associated with 40% reduction in stroke, 25% reduction in myocardial infarction, and 50% reduction in heart failure. We always stress on lifestyle modification before we proceed to pharmacological therapy. Lifestyle modification, you start with your salt intake, has to be less than 1.5 gram a day, less than a teaspoon per day for per an adult per day. And want to stress on stopping smoking, and also you stress to eliminate the trans fat, and you advise to eat whole grains and exercise at least 150 minutes per week, and go up to 300 minutes per week to start losing weight. And you want to counsel about drinking water before meals, half an hour, and keep 2 liters per day. And you want also to stress on the diet, plant, so it's going to be based on plant, high vegetarian diet with low fat and low carbohydrates. When you go to your pharmacological treatment, when do you start pharmacology therapy? Would be when you have stage 1, 130 over 80, remember that, and you have a clinical cardiovascular disease or a 10 years cardiovascular risk more than 10%. All patients with a stage 2 hypertension, you should initiate pharmacological therapy. Lowering blood pressure is more important than the class of antihypertensive drug used to achieve control. Very important. The primary agents is changed now. So beta blocker is not anymore from the first line therapy. The primary agents will be thiazide diuretics or calcium channel blocker or your ACE inhibitor or ARB, angiotensin receptor blocker. For hypertension in general, non-black population, including those with diabetes. In black patient, initial antihypertensive therapy should include thiazide diuretic or calcium channel blocker. Your second line therapy, which are now beta blockers or central or peripheral acting, alpha blockers, your vasodilators, and aldosterone receptor antagonists, and loop diuretics. These one not recommended as first line therapy. Beta blocker you can use for post-myocardial infarction or heart failure. Aldosterone receptor blocker for heart failure. In some circumstances, and loop diuretics for advanced chronic kidney disease. And you can use this second line as an add-on therapy for your resistant hypertension. Hydrochlorothiazide is the most common used thiazide diuretics. We know that, but chlorothalidone is actually is better in the form of it's once a day or every other day dosing, and it's potent and it's supported with many studies, and also it has efficacy in reducing cardiovascular events. So you may consider chlorothalidone on your list. And this is endopamide actually has an advantage here. Maybe preferred in a patient with dyslipidemia or diabetes due to less effects on lipids and glucose than higher doses of hydrochlorothiazide. Maybe more effective in patients even with decreased creatinine clearance than the other thiazides. Hydrochlorothiazide good with the low doses like 12.5 milligram, and it's effective in decreasing mortality, morbidity, and as low as 6.25 milligram, enough to augment other agents. And this quotes from RX file. Loop diuretics you use for symptomatic heart failure or chronic kidney disease with estimated GFR less than 30. This is important. There is always persistent intravascular volume expansion with no obvious edema, contributing to your hypertension that appear resistant to your treatment. Loop diuretic, the furosemide as an example, should be dosed at least 2 to 3 times a day, and higher doses should be used for patients with low GFR. Your potassium sparing diuretics are 2 classes, is aldosterone receptor antagonist, are either spironolactone or eplerenone, and the other class is epithelial sodium channel blockers like amloride, and they are weaker diuretics. And we tend to use these when there is a liver cirrhosis, or severe heart failure, or resistant hypertension. Remember that diuretics are the second line of treatment in pregnancy, and the concern was theoretical intravascular volume depletion. Your calcium channel blockers, you have 2 classes, either dihydropyridine, such as amlodipine or flodipine or nifedipine, and non-dihydropyridine like dialtism or verapamil. Your non-dihydropyridines diminish cardiac contractility, and it has a negative inotrope. Also has an AV nodal blockade effect. So you watch out, and cautious should be taken in prescribing the non-dihydropyridines with the beta blockers. You be cautious when you're prescribing those for patients with heart failure with a severely reduced ejection fraction, or a patient with sick sinus syndrome and a 2nd degree or 3rd degree heart block. Short-acting nifedipine associated with increased mortality if used immediately after acute MI. They have profound hypertension and sympathetic activation. You want to watch out for myopathy if you're using calcium channel blocker, the non-dihydropyridines combined with the high dose of statin. When it comes to the renin-angiotensin system agents, either ACE inhibitor or angiotensin receptor blocker or direct renin inhibitors like alcycrin. This is very important that they do have similar efficacy, the ACE inhibitors and angiotensin receptor blocker on reducing blood pressure and progression of albuminuria and chronic kidney disease, and risk for cardiovascular events. So they all pretty much same effect for ACE inhibitor or ARBs on these cases. You want to watch out for the angioedema as a complication, and it's life-threatening condition, complication of ACE inhibitor or renin inhibitors. Less outcome data on effect of Alzheimer's, but a similar blood pressure lowering effect is expected on this medication. Renin-angiotensin system agents should not be used in combination. You would do more harm if you use them in combined with hyperkalemia and acute kidney injury. And RAS also agents, they are contraindicated in pregnancy. In 2017, ACC and American Heart Association blood pressure guideline recommend combined therapy with the first-line antihypertensive therapy for adults with stage 2 hypertension, an average blood pressure 20 systolic or 10 diastolic above their goal, typically more or equal than 150/90. You start your combination therapy. There are no definite recommendation for the best drug combination, but I would highlight on the accomplished trial that showed the amlodipine, which is dihydropyridine calcium channel blocker, plus benzopro, which is ACE inhibitor, was associated with a 20% lower rate of cardiovascular event compared to hydrochlorothiazide and benzopro. These quotes from UpToDate that in case of non-obese patients who are already being treated with the ACE inhibitor or ARB plus thiazide diuretics and have attained goal blood pressure, UpToDate suggested stopping the thiazide and switching to long-acting dihydropyridine calcium channel blocker like lodipine. In the case of obese patients, combination of ACE inhibitor plus thiazide diuretics can be continued. UpToDate suggests continuing therapy in patients who are well controlled on combination other than ACE inhibitor or plus thiazide. Patients being treated with thiazide diuretics as a monotherapy who have responded but not yet attained goal blood pressure, UpToDate suggests stopping the thiazide and switching to a long-acting ACE inhibitor or ARB plus long-acting dihydropyridine calcium channel blocker. Thank you. I hope you benefit. Thanks.